Okay, what do you do for a career now?
So I am the learning specialist for the IGR program. So I work intensively with students who have challenges with executive functioning as a result, typically of a pre-diagnosed learning difference like ADHD, specific learning disabilities, autism spectrum disorders, varieties of processing disorders, and a couple of mental health conditions that were related to executive functioning, so anxiety, depression, and bipolar disorders those are the big three that we usually see here. But I work with all students who have executive functioning needs related to executive functioning. I also am the online module coordinator for the College Star program, which means that I basically coordinate all of the faculty development modules and case studies for the College Star program. So those are basically UDL practices at a collegiate level in practice. People write about them so they can read them and then implement those in their own classroom. So I do all of that.
Cool. That was a really good answer. Okay. Okay. What is your? You might have said it, but what is your degree in exactly?
Yeah. So I'm a two-time graduate at Appalachian. I graduated with my undergraduate, my Bachelor of Science in Special Education Adaptive Curriculum. And then last May, so May 2018, I graduated with my Master's in Special Education, but that had an emphasis in emotional and behavioral disorders. And then I have a certification or a certificate in autism spectrum disorders.
Okay, cool. All right, so I'm gonna kind of change, like, not really change subject, but okay. So I'm assuming you deal with a lot of students that take ADD medicine. What is your opinion on ADD and ADHD medicine?
Yes, I do. I do work with a lot of students with ADHD, and particularly students who take medication for that. So when it comes to the work that I do with students, I feel that many of them have a good sense of whether or not now medication is useful for them and not. And I work with students who have like a broad variety of medication. So for example, I work with a young woman who doesn't take like a pill for ADHD medicine. It's a patch. So it's like a slow release patch. I work with another student who takes a dose several times a day, like a delayed kind of dosage situation. And then I work with students who take, one pill a day, maybe 2 pills a day, depending on what it is their dosage is. My opinion, when it comes to students who are over 18, I feel like it's their choice. So whether or not they take medicine is entirely up to them. I feel that they are more successful if they do take medication, because it allows them, it helps them pay attention when they need to pay attention. But that doesn't necessarily mean that they're going to pay attention to what they're supposed to be paying attention to. But when it comes to my work in like a K-12 setting, I saw when I was working there, a lot of medication being given to students to manage behavior as opposed to increase access to a learning environment. So my opinion of medication, I'm not a doctor, so it's really hard for me to like make a judgment about whether or not medication is good and bad, because I see the really good results of medication, like my girl who takes the patch, and she'll do probably 5 points better on a test if she's, taking her meds, versus, a student who's in like 3rd or 4th grade, who's bouncing off the walls, who can't attend to a task, who's wiggling in their seat, and their teacher and parents encourage medication and diagnosis of ADHD in order to manage their behavior, as opposed to having them access that learning environment by, increased attention, increased task awareness, those kind of components that also kind of go hand in hand with ADHD. So I feel like we should be teaching students, how to, attend to a task, what are strategies that work for them, as opposed to medicating behaviors. But that's just my opinion.
Yeah, that's really good. That's what I wanted to hear too. Okay. Do you think it's overprescribed?
I would say yes, and I would say because ADHD is overdiagnosed. So certain other disabilities and mental health diagnoses will sometimes manifest like characteristics of ADHD. So for example, students with who have like generalized anxiety disorders will sometimes be misdiagnosed with ADHD because they have so much anxiety, they can't pay attention, they're constantly trying to figure out what's happening next. And so those can kind of come across as ADHD characteristics or ADD characteristics, but in reality, it's actually an anxiety disorder. And so I see a lot of parents, and particularly teachers, who, when a student, doesn't fit this kind of traditional model, they push medication or they push a diagnosis. And so that's kind of what I'm seeing. I'm seeing it kind of be like a fad diagnosis. But I do feel like the increase in diagnosis is warranted as we become more aware of what ADHD looks like in lots of different settings as opposed to just the school setting, and then also what are the different varieties of behaviors that we see from people with ADHD. So, I don't know why I did the gun at the end.
Okay, I have one more question. This is opinionated though. Okay, what do you think is an appropriate age range for or not even an age range. What do you think like an appropriate age would be to start taking ADD medicine?
I can't really answer that question because I don't feel like it's possible to put every single person in a box. So the school system does a very good job of only making the thing that you have in common with your peers your age. And so I don't necessarily agree that that's how we should do school. I think that the way that public school and just school in general functions is very kind of like systematic and mechanical. I would love to see people do a different method of teaching when it comes, particularly in like the elementary school ages. So like for example, how come all of the students who are 11 are all in the same class? Because that's the only thing they have in common is their age. And so it's hard for me to say what a good age would be. I think it depends on when they were diagnosed, what their treatment plans are when it comes to their doctor, what kind of doctors they're seeing. Are they seeing like just a general practitioner, or are they seeing a specialist that specializes in that kind of A, medication, and B, ADHD, and then what their teachers are seeing and what their teachers are noticing about that kid. And I think that we need to do a better job, particularly in education, of understanding that a child's behavior is not always something that needs to be fixed. It's something that we need to look at critically and say, all right, why is this kid out of his seat 24/7? Is it because he has ADHD, or is it because sitting down is actually super uncomfortable for him? Things like that. I think that it's really easy to stick a label on something and just be like, that's it. But I don't really have a good age.
So you're saying that basically like behavior, like bad behavior such as like, and this is for kids who are elementary school, like kids that are like, let's say K through 5, you don't think that like bad behavior such as like fiddling a pencil or like tapping your foot, you don't think that should qualify them to take like Adderall?
Not at all.
No.
I'm like, for me, and this is kind of more of my teaching philosophy, if I have a kid that's not engaging with me, it's something I'm not doing right. So why is that kid not engaged? It's because I'm not teaching something that's interesting and meaningful to them, and it's because, maybe something else is going on in that student's life. And I mean, it might be, a disability related to attention, but odds are I can do something as a teacher to help that student access my instruction. If all the students in my classroom but one are able to access my instruction, it's important for me as a teacher to be able to look at that student and say, okay, what is going on here? What can I do differently to help that student? Maybe they need to sit closer to me. Maybe I need to stand right next to them. I think there's a lot of other things that need to be tried first before we prescribe someone a medication for an undesirable behavior.
Yeah.
I don't think that necessarily, I think very few behaviors are actually bad behaviors. I think like punching your neighbor is a bad behavior, but like tapping your pencil and like getting out of your seat and talking with your neighbor, those are more undesirable behaviors. So if it's undesirable, figure out what you can do in your classroom to work with that student as opposed to
giving them an amphetamine.
Yeah.
All right, that's really all I need.